Good morning. I'm going to talk to you briefly about interventions in acute stroke. And I think part of this has been shown in some of the previous presentations, whether it was talking about carotid stenting or actually stroke. But stroke is the third leading cause of death in the U.S. It's a leading cause of disability. So this is a tremendous issue in the U.S. because most of the patients that have a stroke aren't successfully rehabilitated, and they are young people that are taken out of the workforce. The history of stroke, I think, is very interesting because if we look at it, over 1,000 years ago, patients with stroke were being treated. And their treatment is described in this ancient papyrus, but the treatment is interesting because it contained some medical treatment, but it also contained a lot of magic and mysticism. And I think if you look at what we do in stroke, even in 2013, there's probably still some magic that's being applied to this treatment. Stroke used to be called apoplexy, basically meaning the patients were struck down. Over a couple of thousand years ago, these patients would have these sudden unexplainable fits. In the 1600s, we found bleeding in the brain caused fatal apoplexy in some patients, and also discovered blockage in blood vessels that could cause this apoplexy. But again, the treatment for these patients was really just to feed them, to care, wait, and let it run its course. And a lot of that is still applicable till 2013. Virchow was able to demonstrate with standard autopsy methodology that thromboembolism was a major factor in stroke. And then in 1928, apoplexy was converted to a term called CVA, or cerebral vascular accident. And the term, or sort of the idea of stroke or brain attack, evolved. Just some generic facts about stroke. 2 to 3 out of 100,000 children, these are people less than 14 years of age, per year, 100 per 100,000 adults per year. And there's a geographical area where fatal strokes are more prominent in the U.S., what we call the stroke belt, that sort of goes along the southeastern part of the United States. The different types of strokes, again, categorically hemorrhagic and ischemic, and the majority of strokes are ischemic, which is good because these are strokes that most of us would have an opportunity to treat. The hemorrhagic strokes can be treated by our neurointerventional colleagues, but the prognosis for that type of stroke is much more dismal than the ischemic stroke. So what causes a stroke? It's embolic occlusion rather than intracranial plaque rupture. So this is different from coronary anatomy or coronary circulation. So when we talk about coronary interventionalists going into the brain or doing acute stroke intervention or intracranial angioplasty, we have to understand that these vessels are different from coronary arteries. We also have to understand that the mechanism of the occlusion is different from what we typically see in the coronary circulation. Now, there's been a lot of discussion this morning about carotid endarterectomy, carotid stenting, and the potential of having a stroke as a result of CAS. Most CAS are free of complications, but I think operators should be familiar with the equipment, drugs, and neurorescue before they do this procedure. So we talked about operator experience just to perform the procedure, but I think there's another layer of experience that either you need to have or it needs to be in your institution. That's the idea of having neurorescue available in the event that you do have a stroke as a result of something that you've done in the catheterization laboratory while trying to perform a carotid artery stenting. You must have those supplies in the laboratory to execute rescue. If we think about what happens with stroke or what happens with carotid stenting, you've seen this slide earlier today, but clearly over time the incidence or the risk of adverse events has decreased. Part of this may be operator experience or learning curve. It's also a combination of improvements in technology and a combination of us being more smart as far as which patients we actually choose. So part of the operator experience is not just the technical aspects of it, but it's the cognitive aspect of knowing which patients to do and which patients to avoid. In the event that there is a complication when you're doing CAS or carotid artery stenting, Then your options include mechanical thrombus removal, aspiration, fragmentation, intra-arterial thrombolysis, and stenting. A simple way to look at this, or a simplistic way to look at this, is if you have a neurologic complication while you're performing carotid stenting, do intracranial cerebral angiogram in multiple projections. You should know how to do that. If you don't know how to do that, then you should partner yourself with someone who can do this. And if there's no intracranial vessel occlusion, that would bespeak a TIA or a minor stroke where the prognosis is good. Those patients can be treated with heparin or sometimes with 2B3A inhibitors. On the contrary, if you do see vessel occlusion, it may portend a major stroke. Now, it also depends on where that occlusion is. So just because you see an occlusion doesn't mean that you have to try to intervene. Those patients get intervention that includes polypharmacy and also mechanical intervention. This is a angiogram of an acute stroke patient. I think what you can see is there's an occlusion of the MCA on the right side. And here you see in the triangle the collateral flow. This is something that's typically seen when you perform these angiograms. The flow is very diminished, and you have to visualize for an extended period of time to see where the collateral flow is. This is the lateral view showing the same thing. A microcatheter was inserted over a guide wire. These arrows show you how tortuous these vessels can be. And after the crossing with the microcatheter, a confirmatory injection was performed distally. And with just dottering, you do get some anti-rate flow. And then a small dose of TPA was administered via the microcatheter. When we talk about intraarterial or selective intraarterial TPA, for these acute stroke patients, we're talking about very low doses. So patients that receive anything over 5 milligrams of TPA, that's a very large dose. So in general, it would be 1 to 2 milligrams of TPA that they receive. And this is post-TPA, the occlusion still persisted. A small balloon was used. And then this is the final result. And again, we don't try to get a stent-like appearance of the final result. We want to just restore any rate flow in this patient population. So this is not about beautifying arteries. This is another angiogram that basically, or series of angiograms from one of our publications that shows a microcatheter inserted and then thrombolysis. An acute stroke patient that was treated with PTA following carotid artery stenting. And this is a panel that represents the debris that was removed with a Mercy device. And you can see that this is a very dense looking piece of material, not likely to respond to thrombolysis, and hence why we have dismal results when we use IV thrombolysis in patients that come in out of the hospital with acute stroke. Again, another panel with a Mercy retrieval device. Now, part of the reason of just showing you those devices and showing those cases is because the acute stroke intervention in the United States at the present time is in a flux. And it's in a flux because of several recent publications. This was a publication, it's titled A Trial of Imaging Selection and Endovascular Treatment for Ischemic Stroke. The study did not demonstrate a benefit with a favorable penumbral pattern. So these patients were imaged if they had a penumbral pattern, which meant that they had viable brain tissue that was likely to improve with intervention. But overall, there was no benefit from mechanical thrombectomy versus standard medical therapy in that patient population. Another study, all of these studies came out around the same time, endovascular therapy and intravenous TPA versus TPA alone for stroke. And again, similar outcomes for safety. The study was actually stopped prematurely because of the futility after over 600 patients had been randomized to either endovascular therapy or IV TPA alone. And then another study, endovascular treatment for acute ischemic stroke. 362 patients with acute ischemic stroke were randomized endovascular therapy, and that included a multitude of options: intraarterial thrombolysis, mechanical clot disruption or retrieval, or a combination thereof, versus IV TPA. And the primary outcome was disability-free survival. But again, the endovascular therapy was not superior to standard therapy with TPA. Now, you'd have to understand the field of acute stroke intervention to really be able to critique these studies well. And I think one of the things that has come out of looking at a study or this series of studies is that, number one, the time to these patients being treated was excessively long, and the devices that were used were not the best devices that we have on the shelf right now. And clearly, this is not, I think, the end of endovascular therapy for acute ischemic stroke, but certainly it would raise questions as to whether or not we should continue with these devices. Now, there are a couple of other trials. This was the Treble versus Mercy Retriever. The Mercy Retriever is the one that I showed you on the earlier panels. And in this study conducted from February to December, 88 patients that had this retriever device were randomized compared to patients using the Mercy retrieval device. And the Treble device was better or met the primary endpoint more than in the Mercy device. Here we see an occlusion of a MCA. It's not showing up well, but on the next panel on the right-hand side at the top, that's the retrieval device. And then the left-hand lower panel, you can see that the vessel is patent. And then in the right-hand lower panel, you can see the retrieval device with the clot. So mechanistically, what you're doing is you're deploying a stent, either deploying the stent, leaving the stent, or deploying a stent to grab the thrombus and then removing the stent. So their conclusion was patients with large vessel occlusion strokes that were either ineligible or refractory to IV-TPA should be treated with this device in preference to the Mercy retrieval device. And we know, from our IV thrombolysis experience that patients that have large vessel occlusion don't respond to IV-TPA. Another trial looking at the Solitaire device, to go through this quickly, this was a trial, again, looking at a patient population with acute stroke. And you can actually look these up for yourself. But the trial results showed that this was, again, a better device than the Mercy retrieval device. So let's put this in perspective. There are about 800,000 strokes in the U.S., 100 to 200,000 are large vessel occlusion. So these are patients that aren't going to respond to IV-TPA. Only 3% of patients get IV-TPA, and even if these were part of that 3%, they're not going to respond. And so these are patients that I still feel that we should be working on trying to treat these with endovascular therapy. You can see in the red box there that there are a number of issues that are barriers in this type of treatment, including the lack of enough specialists to do it, the coverage, recognition, et cetera. I think the future randomized trials that are well designed need to be performed. We need to minimize the treatment or time to treatment, just like the door balloon time. And for the coronary circulation, there needs to be an initiative for patients with acute stroke to be treated in an expeditious manner, not like it was in some of these trials where it was over 5 hours, where a lot of these patients were actually intervened on. We need better operators, and we need better devices. Thank you very much.
1.5 minutes for questions, please.
So after this study of New England Journal of Medicine, what is the current approach for treatment of acute stroke? Whether interventions or no interventions? Only TPA?
No, I think the patients that receive TPA, and this is the FDA-approved treatment for acute stroke, only about 3% of patients actually receive TPA. The endovascular treatment, I think, is still something that we need to investigate, in particular for the patients that have large vessel occlusion, because those are the patients that don't respond to TPA even if they got it, and those are the patients that have a worse prognosis, not only disability but actually mortality. The issues with these trials are that when the insurers look at trials like this, it's another excuse for them not to pay. And so if there's no payment or no funding, then patients are going to suffer. And so my fear is more that the ramifications from this would be more, from a third-party payer as it is from the medical community. I think the medical community, we have some targets. We need to work faster. We need better equipment. we need better trials, and then we need to continue to work at this. But we shouldn't give up because these patients don't do well.